Welcome back to the Vital Signpost, ready for another deep dive.
Always.
Today we're tackling a topic that's, well, vital, especially for nurses like us.
You're talking about thyroid function.
Right, exactly. That small but mighty gland that can really throw the body for a loop if it's not working properly.
No kidding. For such a tiny gland, the thyroid has a huge impact on just about every system in the body.
It really does. So let's start with the basics. Where is this little powerhouse located, and what exactly does it do?
Okay, so picture this. You're examining a patient's neck. Right across the larynx, below the Adam's apple, you'll find the thyroid gland.
Oh, right on the windpipe.
Yeah, wrapped right around the trachea. It has two lobes connected by a band of tissue called the isthmus, kind of like a butterfly shape.
A butterfly that's pumping out hormones that affect everything from our energy levels to our metabolism.
Exactly. And speaking of hormones, the thyroid is responsible for producing three main ones.
Those are T4, T3, and calcitonin, right?
You got it. Thyroxine, or T4, and triiodothyronine, or T3, are the big players when it comes to regulating metabolism. They control how our bodies use energy, which affects everything from weight to temperature to heart rate.
It's amazing how much those two hormones control. And then calcitonin plays a role in calcium regulation, which is essential for bone health.
Right. Now, the way these hormones are produced is actually pretty fascinating.
You know, that's one thing that always confused me in nursing school. It just seemed so complicated.
It is a bit complex, but think of it this way. The thyroid gland pulls iodine, which we get from our diet, from the bloodstream.
So that's why iodine is so important for thyroid health.
Absolutely. Inside the gland, iodine combines with an amino acid called tyrosine, and through a bunch of reactions and enzymes, boom, you get T4 and T3.
So it's like iodine is the essential ingredient in the recipe for thyroid hormones. But how does the body know how much of those hormones to make? It's not like the thyroid just churns them out randomly.
Nope, not at all. There's a feedback loop at play here. It involves the pituitary gland, which sits at the base of the brain. Think of the pituitary as the thyroid's boss.
The pituitary's in charge. I like that.
Exactly. The pituitary releases a hormone called TSH, or thyroid-stimulating hormone. When T3 and T4 levels in the blood are low, TSH tells the thyroid, hey, we need more hormones, step it up.
And when those hormone levels are high, TSH production goes down, right? Telling the thyroid to ease up a bit.
Precisely. It's a delicate dance, constantly adjusting to keep everything in balance.
Just like so many things in the body, it's all about maintaining that sweet spot. Now, let's talk about what happens when this communication gets disrupted and things go wrong.
Because we know thyroid disorders are pretty common, especially as people get older.
Right. And they can be tricky to spot sometimes because the symptoms can be so subtle, especially in older adults.
Absolutely. Broadly speaking, thyroid disorders fall into two main categories: hypothyroidism, where the thyroid isn't producing enough hormones, and hyperthyroidism, where it's producing too much.
And both conditions can cause a whole range of symptoms, some of which can mimic other conditions.
Which is why a thorough assessment is so crucial. We need to be asking those targeted questions, listening to what our patients are telling us, and paying close attention during our physical exams.
We have to be real detectives looking for those subtle clues. So let's start with hypothyroidism. What are some of the red flags that should be on our radar?
With hypothyroidism, think slowing down. Everything in the body starts to run a bit sluggish. You might see fatigue, weight gain, dry skin, constipation, cold intolerance, and even depression.
It's like the body's metabolism is stuck in low gear. And as we said, these symptoms can be easily missed or attributed to other things, especially in older adults.
Exactly. They might just think it's part of getting older. That's why taking a thorough health history is so crucial. We need to ask about specific symptoms, when they started, how severe they are, the whole picture.
And of course, we can't forget about those lab tests. Those are essential for confirming a diagnosis and monitoring treatment.
Absolutely. A simple blood test can measure TSH levels. If they're elevated, that's a strong indication of hypothyroidism. We might also want to check T4 and T3 levels for a more complete view.
Okay, so we've got the basics of hypothyroidism down, but what about the flip side? Hyperthyroidism. What should we be on the lookout for there?
Hyperthyroidism is like hitting the fast-forward button on the body's metabolism. Think rapid heartbeat, weight loss despite a good appetite, tremors, anxiety, insomnia, heat intolerance.
It's like everything is running on overdrive. And sometimes you even see those bulging eyes, right?
Right, that can happen in some cases. It's a condition called exophthalmos, and it's often associated with Graves' disease.
Which is one of the common causes of hyperthyroidism, right?
Exactly. Graves' disease is an autoimmune disorder where the body's immune system mistakenly attacks the thyroid gland, causing it to overproduce hormones.
So the body is essentially attacking itself, leading to all those hyperthyroid symptoms.
Yep. Another cause is Plummer's disease, where nodules in the thyroid gland start secreting excess hormones on their own.
So in both cases, the thyroid is just pumping out way too much hormone, throwing the body out of whack. And just like with hypothyroidism, those lab tests are key for making the diagnosis and guiding treatment.
Absolutely. We'll be looking for low TSH levels and elevated T4 and T3 levels in hyperthyroidism. Now, managing these thyroid disorders often involves medication, and that's a whole other conversation.
It is. And we'll definitely dive into those medications in our next segment. But for now, let's take a quick break. Stay tuned, because we'll be back to explore the world of thyroid medications and how they help our patients find that balance again. And we're back, continuing our deep dive into the world of the thyroid. We've talked about what this gland does, how it can go wrong, and now it's time to tackle the medications that help our patients manage these conditions.
Sounds good to me.
Let's start with hypothyroidism. What are the go-to treatments when the thyroid isn't producing enough hormones?
Well, the goal is to replace those missing hormones to bring things back into balance.
We're giving the body what it needs, basically.
Exactly. And the gold standard for hypothyroidism treatment is levothyroxine.
Levothyroxine, that's a synthetic form of the T4 hormone, right?
That's right. It's incredibly effective. We also have natural thyroid medications, which are derived from animal thyroid glands.
I remember learning about both types in nursing school, but I have to admit, I always felt more comfortable with the synthetic medications.
I understand. They're more predictable in terms of their composition and dosing.
Why is levothyroxine the preferred choice these days?
It comes down to consistency and purity. Levothyroxine is 100% T4, so we know exactly what we're giving. Natural thyroid preparations can vary in their hormone composition, which can make dosing a bit tricky.
That makes sense. Consistent dosing is so important for these patients.
Absolutely. And levothyroxine is just once a day, which is great for patient adherence.
Oh, that's always a bonus,
Yeah.
especially for patients juggling multiple medications. Speaking of administration, are there any key things nurses should keep in mind when it comes to giving levothyroxine?
One of the most important things is absorption. For optimal absorption, levothyroxine should be taken on an empty stomach first thing in the morning, at least 30 to 60 minutes before breakfast.
So no coffee with their meds.
Nope, food can interfere with how well the medication is absorbed. We also need to be aware of potential interactions with other medications.
Oh, right. Like what kinds of medications?
Certain medications, like antacids, iron supplements, and even some cholesterol-lowering drugs, can affect how levothyroxine is absorbed. So always review a patient's full medication list and check for potential interactions.
It's like being a medication detective. So we've given the medication, we've considered those interactions, but how do we know if the levothyroxine dose is correct? How do we monitor that?
We go back to those trusty lab tests. We monitor TSH levels to see if they're within the normal range.
Right, because TSH tells us how much the pituitary is stimulating the thyroid.
Exactly. And it might take a few weeks for the medication to fully kick in and for the TSH levels to stabilize. So we'll usually recheck TSH after about 6 to 8 weeks of starting levothyroxine or after any dose adjustment.
So patience is key. And of course, we need to educate our patients about potential side effects and when to call their doctor.
Absolutely. Levothyroxine is generally well tolerated, but like any medication, there are potential side effects, especially if the dose is too high.
What are some of the things patients should watch out for?
Things like rapid heartbeat, palpitations, nervousness, insomnia, even chest pain. These could be signs that the medication is pushing the metabolism into overdrive.
Okay, so we've covered hypothyroidism pretty well. Now let's shift gears and talk about managing that overactive thyroid. Hyperthyroidism. What are our options there?
For hyperthyroidism, we have a few different approaches depending on the cause and severity. One option is to use antithyroid medications, which work by blocking the thyroid from producing excess hormones.
So instead of replacing hormones, we're trying to reduce production.
Exactly. And the two main antithyroid medications we use are methimazole and propylthiouracil, or PTU for short.
I remember those names from pharmacology. How do they work?
They both work by preventing the thyroid from using iodine to make hormones. It's like cutting off the supply line.
Makes sense.
Yeah.
And I know you mentioned iodine restriction earlier. Does that apply to patients taking these medications too?
Yes, absolutely. Even if they're on medication, high levels of iodine can interfere with how well those medications work.
So it's a multi-pronged approach,
Yeah.
medication and dietary changes. Now, are there any key differences between methimazole and PTU?
There are some important distinctions. PTU has the added benefit of blocking the conversion of T4 to T3 in the peripheral tissues. It also tends to work a bit faster than methimazole, though both drugs can take several weeks to have their full effect.
So PTU has a couple of extra tricks up its sleeve. Are there any situations where one drug might be preferred over the other?
There are a few scenarios. For example, PTU is often the preferred drug during the first trimester of pregnancy. There are concerns about potential risks with methimazole during that time. However, it's important to note that both drugs carry some level of risk during pregnancy, and the decision should always be made in consultation with the healthcare provider.
Right, it's all about weighing those risks and benefits. Speaking of risks, what about side effects? Are there any particular concerns we should be aware of with antithyroid medications?
Both methimazole and PTU can cause side effects, and some of them can be quite serious. One of the most concerning is liver toxicity, which can be life-threatening in rare cases. Patients taking these medications need regular monitoring of their liver function through blood tests.
Oh, wow, that's serious. What are some of the signs and symptoms of liver problems that we should teach our patients to watch out for?
Things like jaundice, which is a yellowing of the skin and eyes, dark urine, fatigue, loss of appetite, and right upper abdominal pain. We need to catch these issues early.
So we're really emphasizing patient education here, making sure they know what to watch out for and when to seek medical attention.
Exactly. Now, besides liver problems, there are other less serious side effects that are more common.
Like what?
Things like skin rashes, itching, joint pain, and nausea. These usually subside over time, and there are ways to manage them, but it's important for patients to report any new or unusual symptoms to their doctor.
Always better to be safe than sorry. Now, we've talked about medications that replace thyroid hormone and those that block its production. Are there any other treatment options for hyperthyroidism?
Yes. In some cases, especially if medications aren't working well or there are concerns about side effects, we can consider radioactive iodine therapy or surgery to remove all or part of the thyroid gland.
So those are options for more severe or persistent cases. It's amazing how many different approaches we have for managing these thyroid disorders.
It is, and it highlights the importance of individualized care, really tailoring the treatment plan to each patient's unique needs. But we also need to remember that managing thyroid disorders isn't just about medications and procedures.
It's about the whole person, right? Their physical health, their emotional well-being, their quality of life.
Absolutely. These conditions can affect every aspect of a person's life.
So how can we, as nurses, provide that holistic care that these patients need?
It starts with listening. Really listening to our patients, trying to understand how these conditions are impacting their lives, not just their physical symptoms, but their emotional and social well-being too.
It's about validating their experiences and letting them know they're not alone in this journey.
Exactly. We can also empower them through education, making sure they understand their condition, their treatment options, the potential side effects of their medication.
Knowledge is power.
Yeah.
Giving them the information they need to actively participate in their care.
And we can connect them with resources like support groups or online communities where they can connect with others who are going through similar challenges.
That sense of community can make such a difference, especially when you're dealing with a chronic condition like thyroid disease. You know, this deep dive has really given me a renewed appreciation for the complexities of thyroid function and care.
Me too. It's such a fascinating area of nursing. And it's a reminder that learning is a lifelong journey, especially in our profession. Now, I think it's time to put your thyroid knowledge to the test.
Yes. Are you ready for some review questions?
Hit me with them. I'm ready to see what you've learned.
All right, it's time to put that thyroid knowledge to the test. Are you ready for some review questions?
Bring them on. Let's see what you've learned.
Okay, first question. When monitoring the laboratory values for a patient who is taking antithyroid drugs, the nurse knows to watch for which of these? Now, this is a multiple choice question with 5 options.
Okay, hit me with the options.
Option A, decreased platelet counts. Option B, increased white blood cell counts. Option C, increased blood urea nitrogen level. Option D, increased blood glucose level. And option E, decreased creatinine levels. Take your time, think it through. What do you think?
Well, we know those antithyroid drugs can sometimes have side effects, and some of those side effects can affect the blood, right?
Exactly. So we need to think about which of those lab values would be a red flag. Let's start with option A, decreased platelet count. What do platelets do again? Those are the tiny cells that help with blood clotting, right?
Right, so if someone has a low platelet count, they're at a higher risk of bleeding.
Exactly. And a decreased platelet count could be a sign of bone marrow suppression, which is a potential side effect of some antithyroid medications. That one definitely seems like a concern.
Yeah, that's one we'd want to watch closely. Now, option B, increased white blood cell count. That usually means the body's fighting off an infection.
Right. Those white blood cells are immune system warriors. And that's not usually related to antithyroid medication, so we can probably rule that one out.
Agreed. How about option C, increased blood urea nitrogen level? BUN is a marker of kidney function. If those kidneys aren't filtering waste products properly, that BUN level will go up.
So could antithyroid medications affect the kidneys? I don't remember learning about that.
In some cases, yes. Some of those drugs can cause inflammation in the kidneys, which could lead to that increased BUN level. So this one's also a potential concern.
Okay, so we're keeping an eye on both platelet counts and BUN levels. Option D, increased blood glucose levels. That's more of a diabetes thing, right?
Exactly. That's all about sugar levels, not directly related to how antithyroid medications work. And option E, decreased creatinine levels. Creatinine is another marker of kidney function, but a decrease isn't usually a cause for concern.
Okay, so it sounds like the correct answers are options A and C, decreased platelet counts and increased blood urea nitrogen level.
You got it. It's so important for nurses to recognize those red flags in lab results, especially when it comes to medication safety.
Absolutely. Okay, ready for question number 2?
I'm ready.
The pharmacy calls a patient to notify her that her current brand of thyroid replacement hormone is on back order. The patient calls the clinic to ask what to do. Which is the best response by the nurse?
Oh, that's a tough one. It happens all the time, though.
It really does. And we have a few options here. Option A, go ahead and take the other brand that the pharmacy has available for now. Option B, you can stop the medication until your current brand is available. Option C, you can split the thyroid pills that you have left so they will last longer. And option D, let me ask your prescriber what needs to be done. We will need to watch how you do if you switch brands. What do you think is the best course of action here?
Well, it can be tempting to just say switch brands, but we have to be careful with thyroid medications. Even small changes in those inactive ingredients between brands can affect how the drug is absorbed.
Right, and that could really mess with the patient's hormone levels. And stopping the medication altogether is definitely not a good idea.
No way. Thyroid hormone replacement is usually a lifelong therapy, and suddenly stopping it could cause all sorts of problems.
And what about splitting the pills? Could that work?
Not really. Thyroid medications are very precisely dosed, and splitting them could lead to inaccurate dosing, again, affecting those delicate hormone levels. So that leaves us with option D, consult with the prescriber.
That's the safest bet, right?
Yeah.
It emphasizes that personalized care and shows respect for the prescriber's expertise.
Exactly. Always loop in that prescriber when there's a question about medication changes. Okay, what's the next question?
All right, here's question number 3. The nurse is assessing a 72-year-old patient who will be starting thyroid replacement therapy. Which statement is true regarding the dosage of thyroid replacement hormones for older adults?
Okay, older adults. We have to be careful with medication dosages in that population.
We do. So here are the options. Statement A, thyroid hormone replacement requirements approximately 25% lower for this age group. Statement B, older adults require higher dosages of thyroid replacement hormone for therapeutic effects. Statement C, there is no difference in the dosage of thyroid replacement hormone in older adults versus younger adults. In statement D, the dosage of thyroid hormone will depend on the amount of iodine in the patient's diet.
All right, let's break those down. Statement A says older adults need lower doses of thyroid replacement hormone. That sounds familiar, doesn't it?
It does. Older adults tend to be more sensitive to medications, and they often have slower metabolisms. So starting low and going slow makes sense.
Right. We don't want to overload their systems. So that means statement B, saying older adults need higher doses, is definitely false. And statement C, saying there's no difference in dosage based on age, that doesn't seem right either.
Nope, we know age plays a role in how the body handles medications. What about statement D, the one about iodine intake?
Well, iodine is definitely crucial for making thyroid hormones. But the dosage of replacement medication is primarily based on the individual's lab results, specifically their TSH and thyroid hormone levels, and how well they're responding to treatment.
So it's more about those lab values than dietary iodine, which means statement A is the winner. Thyroid hormone replacement requirements are often lower for older adults.
Exactly. It all comes back to that individualized care and careful monitoring.
Okay, 2 more questions to go. Ready for number 4?
Ready.
The nurse is giving an intravenous dose of levothyroxine. The order reads, give 0.1 milligrams IV couche now. What is the ordered dose in micrograms?
Ah, a dosage conversion question. We have to be sharp on those.
We do. Do you remember the conversion factor for milligrams and micrograms?
Let's see. 1 milligram is equal to 1,000 micrograms.
That's it. So to convert zero point 0.1 milligrams to micrograms, we just need to multiply.
Okay, so 0.1 milligrams times 1,000 micrograms per milligram equals 100 micrograms.
That's exactly right. Those dosage conversions are so important for safe medication administration. We don't want to give the wrong dose.
Absolutely not, especially with a powerful medication like levothyroxine. Okay, what's our last question?
All right, last one. Which laboratory tests does the nurse know are used to monitor thyroid hormone replacement therapy?
Okay, lab tests, gotta know those. What are our options?
Option A, serum TSH. Option B, BUN. Option C, CBC. Option D, free thyroid hormone levels. And option E, serum iodine levels.
All right, so we're thinking about which tests give us the best information about how someone is responding to their thyroid hormone replacement. We've talked a lot about TSH, and I know that's super important in regulating thyroid hormone production.
So serum TSH, option A, seems like a must-have. It tells us how the pituitary gland is reacting to the levels of thyroid hormone in the blood.
Definitely. It's our go-to for monitoring the effectiveness of treatment. Now, BUN, option B, tells us about kidney function. It's important overall, but not directly related to thyroid hormone replacement.
So we can probably skip that one. Option C, the CBC, that's a good overall health check, but it doesn't give us specific information about thyroid function.
Right. Now, option D, free thyroid hormone levels, that seems pretty relevant, don't you think?
Definitely. Measuring those free T3 and T4 levels gives us a really clear picture of how much active thyroid hormone is actually available to the body.
It's crucial information for monitoring those hormone levels. And option E, serum iodine levels. While iodine is super important for making thyroid hormones, we don't routinely measure those levels to monitor hormone replacement therapy.
Okay, so that leaves us with options A and D, serum TSH, and free thyroid hormone levels. Those two tests really give us the best picture of how a patient is responding to their medication.
You nailed it. We've covered a lot of ground in this deep dive, from the anatomy and physiology of the thyroid gland to the medications used to manage those common thyroid disorders.
It's been quite a journey. But we've also learned about the importance of individualized care, careful monitoring, and really listening to our patients.
Exactly. And remember, learning is a lifelong process, especially in nursing. So keep those brains engaged and stay curious about the amazing world of the human body.
Absolutely. And thanks to all our listeners for joining us on the Vital Signpost. We'll see you next time for another deep dive into the world of nursing.